Welcome to the Plastic Surgery Podcast, where we talk about all topics involving plastic surgery, of course. I am Philemon Viennes. That is Dr. Lambros Viennes to my left. This week, we are going to be continuing with skin cancer, but we're going to be discussing non-melanoma skin cancer. So, last week, we discussed melanoma.
Correct.
This week, we're going to discuss all the other skin cancers besides melanoma. So there are different types of skin cancers.
Right.
Besides, the most common one is melanoma, or the most general, I assume, that people know about is melanoma. That's the most that you hear people talking about, right?
Yes. Yes, as far as the cancers are concerned. But the most common are the non-melanoma.
So the non-melanoma,
yes, those are the most common.
Okay, so what are non-melanoma skin cancers?
Well, the most common non-melanoma skin cancers are called basal cell carcinoma and squamous cell carcinoma. Typically, they arise from the superficial layers of the skin.
And you mentioned that these were the most common out of all the skin cancers?
Yes.
How common are they?
Well, there are more than 1 million of these skin cancers that are diagnosed per year in the United States, and they also account for the number one cause of cancer in the U.S. as well.
Out of all cancers?
All cancers, yeah.
They're the number one?
They're the number one,
Really?
Yes.
Wow. How are they so common? What exactly causes these skin cancers?
Well, the number one cause is ultraviolet light.
Really?
Sun damage, yeah. So patients who develop skin cancers, such as basal cell and squamous cell carcinoma, typically have a history of chronic sun exposure. And the ultraviolet light, of course, damages the DNA, which leads to mutation of the skin cell, and that results into a malignancy.
Are all skin cancers caused by UV rays?
Not all of them, but the basal cell carcinoma more commonly, ultraviolet light, squamous cell carcinoma as well, but also squamous cell carcinoma is a little bit more unique in that it can be caused by other factors, such as chronic irritation from, let's say, inflammatory skin problems. Patients may have an ulceration that is not healing, and squamous cell carcinoma can arise from that. It can also arise from scars, like a burn scar. Also, patients that are immunosuppressed, such as transplant patients that have to take immunosuppressive drugs, they are also susceptible to developing squamous cell carcinoma. Okay. So squamous cell carcinoma has some other etiologies,
right? But
sun is usually the number one cause. Yeah, number one cause for both the basal cell and the squamous cell.
Right, and also melanoma.
And melanoma,
as
correct.
Well.
Yep.
So before we get into each one specifically, do these skin cancers spread to other parts of the body?
Well, the basal cell carcinoma...
Or I should say, can they spread?
Yes, potentially. But the basal cell carcinomas notoriously locally invade the tissues. They can continue to grow if left untreated, and they can erode into the deeper structures of your skin, soft tissues, down to the layer of the bone. So they can be very locally invasive, but the chances of a basal cell carcinoma to metastasize to another part of the body is very, very low. Now, squamous cell carcinomas have a little bit higher incidence, like less than 5% chance of metastasis, but they are both relatively low. Now, you also have to distinguish between those that arise from the skin cells versus those squamous cell carcinomas that may arise from your mucous membrane, such as your mouth, your lips, genitalia, in and around the anal area. That mucosa, if a squamous cell carcinoma is diagnosed in those areas, those tend to be a little bit more aggressive, and those can metastasize, and they have to be treated a little bit more aggressively than the skin cancers are.
Just very briefly, what is the difference between a basal cell skin cancer and a squamous cell?
So it depends on the origin of the cell. Now, they're both cells within the skin layer. The basal cell is the very bottom cells that actually create the cells as they advance into the upper layers of the skin. So the skin is constantly sloughing the outer layer, and the cells tend to move up from the deeper structure of the skin. So we're talking about very, very superficial skin layers. So those are the basal cells that are at the bottom. And as they advance along the column of cells to the more superficial layers, they're called the squamous cells. So the squamous cells arise from the squamous epithelium, and the basal cell from the basal layer, from the bottom layer.
Why are they called carcinomas?
Because they are cancers.
Oh, so a carcinoma is
a cancer.
Is a cancer.
Yes.
What do these skin cancers look like? Are they different in the two types of cells?
Well, they may have similar features. Now, they may arise and they may look like a little red patch on the skin. They could have an ulceration. It could be slightly raised, non-pigmented. They may have an ulcer, in other words, a breakdown of the skin centrally. And they may have like a scaly look, like a peeling skin in that area. But having said that, though, you can have a pigmented basal cell carcinoma, so they can have some pigmentation sometimes. Typically, if a patient develops a new skin lesion that doesn't go away, or if it bleeds or itches, then we're worried about a skin cancer in those patients.
So is it pretty distinct that you can find these?
Well, usually the patient will recognize a new growth on their skin.
Right.
And then they'll typically go to their family doctor
right.
or dermatologist.
I guess so. It's not like, it wouldn't be just like, it wouldn't look like any old rash, for example, right?
Right. A rash may have a little more broader distribution, and there's some findings that you look at, but usually a rash, when you treat it, will go away.
Right.
Whereas skin cancer will continue to grow.
Right.
Sometimes patients will develop a raised lesion, and they may scratch it, they may pick at it, and it'll go away, they'll say, and then it'll come back again. So lesions that continue to grow, or lesions that may bleed or itch or have any changes that occur in the skin, those are the ones that need to be evaluated for skin cancer.
Right. How do you treat these?
Well, the gold standard is removal of the skin cancer.
Right.
That's usually what is recommended for skin cancers. Now, if you have a very superficial skin cancer, such as a very superficial basal cell carcinoma, sometimes a dermatologist will destroy them through freezing, using liquid nitrogen. Yeah, it's almost like a pen, and they freeze the tissue in order to destroy the cancer cells. Or they'll scrape the top, and then they'll cauterize the base. Sometimes they'll also use chemical agents, or even use chemotherapy drug on, as long as it's a superficial. The deeper ones typically are excised.
So it's surgery?
Yes. And so with surgery, you can get over 90% cure, whereas some of those other modalities, there is an increased risk of recurrence if you do that. But sometimes they can be so small that by just destroying it, it can take care of the...
Really?
As long as the patient has some type of follow-up with their dermatologist. So they may, scrape it away, burn it, or whatever they decide to do to destroy the cells. And then they'll need some type of follow-up afterwards to make sure it doesn't come back. And if it does come back, then they'll remove it.
Right.
Now, some patients that are older or may not be able to tolerate an operation, those patients can also be referred for a radiation therapy. You'll have a risk of recurrence with those, but at least it'll treat that skin cancer. So that's another modality that's used.
After you make a visual diagnosis, if you think it is a skin cancer, do these also undergo biopsies too?
Yes.
Does a surgeon also take a biopsy?
A biopsy, yes, to confirm and establish a diagnosis.
Right. Just a quick comparison. Are the basal cell and squamous cell carcinomas less deadly than melanoma?
Yes.
Because they're less invasive in the body?
Yes, exactly. They have a lower risk of metastasis.
Right, and spreading.
Exactly. Having said that, though, as I mentioned earlier, squamous cell carcinomas can spread.
Right. So we know the difference now between a basal cell carcinoma and a squamous cell carcinoma. How are those different than the melanoma in formation?
So the melanoma, as I mentioned earlier, arises from a melanocyte, which are those cells that create the pigment in the skin.
Okay.
Whereas these are the actual structural layers of the skin.
Right. And why is the melanoma more likely to spread than these?
Well, it's the natural history of the actual tumor. So they tend, when they grow, they have a propensity for spreading.
So it's the type of tumor that forms.
Yes.
Is more likely to spread for the melanoma than for these other two.
And there are all types of cellular events that occur with the membranes of these cells that affect their ability to actually grow and spread.
How can these skin cancers actually cause harm and then kill people?
One of the problems, again, if left untreated, a basal cell carcinoma can potentially continue to grow. It can erode into your tissues. It can get to the point where it erodes a full structure. It could erode through your nose. It could erode through your lip. And then it becomes more of a problem to remove. And it can cause a lot of distortion. If you have an open wound from these cancers, you can develop an infection.
Right.
Yes. So there are a lot of other things that can happen too with these skin cancers. If they're around the eyes, they can erode into your eyelid.
Right.
It could be very disfiguring.
Right.
So it does come with a lot of complications if left untreated.
And with melanoma in particular, when it spreads, basically that skin cancer and skin cancer in general kills cells. It kills your body's cells, correct? It mutates them.
Well, they increase in number. They lose their inhibitory phase. In other words, these cells continue to grow and grow and grow. And as they grow, the answer to your question is yes, they can die centrally within a tumor if there's a lack of blood supply. As the tumors grow, they also stimulate a lot of other events that occur, like blood vessels growing into it to feed it.
Right.
They have sense signals and things like that in the environment.
Right.
So, but as the tumors grow, especially the larger ones, the central core of that tumor may die. The cells may die because they don't get enough blood supply, because these are rapidly dividing cells. And so they need blood flow, they need nutrients and so forth. So if they don't get that, then those would die there. But these tumors, the problem is that once they get into your lymphatic system, or they can even
vital
possibly
organs.
if they move to other areas of the body through the bloodstream, then they can affect other organs, and that's how patients may develop a lot of problems.
And failure of those vital organs, right?
Exactly right.
You have a topic on here that I have no idea about, and it's called Mohs Surgery. Is that correct?
Yes.
So what is that?
Mohs surgery is usually done by a dermatologist. They're specially trained in not only dermatology, but also pathology.
Right.
And they remove these non-melanoma skin cancers in their office. They take samples of the tissue and they slowly remove the edges of the cancer little by little in order to preserve the tissues as much as possible. So as they remove bits and pieces of the tissue, they look at it under the microscope to determine whether or not they've removed all the cancer cells at real time. What they do in their office is they will remove the skin cancer incrementally and then check the margins to make sure that they're negative for tumor. So they slowly remove pieces of the tissue and analyze that tissue under a microscope. And that allows them to preserve the surrounding structures and also assure that all the cancer has been removed. They have a higher cure rate than just direct excision. Now, if you decide to do a direct excision and remove it and close it, you usually still send that tissue to the pathologist to make sure the margins are clear. And that is another method, but the Mohs surgery is a little bit better as far as getting clear margins.
Wait, why is that though?
Because what they'll do is they'll actually map out the edges of the cancer, and they make sure that all those edges are removed. Whereas if you do a direct excision and you send it to a pathologist, it's like cutting a loaf of bread. As you cut across it with these little tiny, slices that you do, you may miss the cancer cell maybe on the edge.
Right.
Whereas the Mohs surgeon will actually look at all those edges. They look at all the edges.
So is that the most common surgery with basal cell?
Yes. Most of the skin cancers removed are performed by Mohs surgery.
Are those the only three types of skin cancer? Basal cell, squamous cell, and melanoma? Or
no, there
are
are other non-melanoma skin cancers, such as the Merkel cell carcinoma, which is relatively rare, and that usually arises from what they call neuroendocrine. It's a neuroendocrine tumor that is relatively invasive. Those need wide excision and usually radiation afterwards to control the margins to reduce the risk of spread. And other cancers that can arise from skin also include, and these are very rare, they can arise also from your sweat glands as well. So, and I've seen a couple of those in the past where patients have looks like a cyst, and you'll remove it, and then they'll have what they'll term it as a squamous cell carcinoma differentiation from the cyst. So it can occur from any of the structures that are in the skin cells, but they're relatively rare.
Right. So these are the most common.
The most common are basal cell, and then the next, basal cell is the most common.
Right.
That's probably 90% of those non-melanoma skin cancers.
Yeah.
And all the rest are either mostly squamous cell, and then the other subsets that I talked about.
Okay. You are a plastic surgeon, obviously. So where do you fit in all this?
Well, my role mainly is to restore form and function. And usually I'm called in for soft tissue coverage of large areas. So most of these skin cancers are diagnosed when they're very small, and they can be handled by dermatologists, and some surgeons will also remove some skin cancers as well. And they can pretty much close most of those. But the ones that are very large or in cosmetic sensitive areas such as the face that can cause distortion of the eyelids or the nose or the mouth. Those are the cases I'm usually asked to come in to help with closure of those wounds. If we have large areas on the body that can't be brought together and closed, sometimes we will use skin grafts. Sometimes we have to recruit tissue from other parts in order to not only bring skin in, but we also may need some fat tissue or some muscle tissue to fill in the defects. We may have to cover bone or joints on the body or tendons. So we use those other methods such as skin grafts and skin flaps to restore that tissue.
So basically, your job is closure and then beautification, I guess you could say.
Exactly. To restore the aesthetic appearance of the patient. And also to cover areas there could be blood vessels exposed, there could be nerves or joints or tendons.
But it's all post removal of the skin cancer.
Right. So if a patient has a large skin cancer that is removed, we kind of know in advance that this patient will need require plastic surgery. So that's coordinated between myself and usually a surgical oncologist, because the surgical oncologist will typically see the patient or have the patient referred to them, and they may have to remove a good portion of the scalp, maybe some of the bone on the scalp, and they may have to get the brain covered or something.
Right. And then
I would have to bring in tissue from another part of the body and to reconstruct that area.
Okay, well, that is all for this week's episode of the Plastic Surgery Podcast. Thank you so much for watching. Next week, I think we're going to go back to cosmetic surgery because we've been discussing reconstructive surgery for the past couple weeks. Look for next week's episode. We're going to be right back here again. Thank you again for watching and have a wonderful week.